Welcome to the deep dive. Today, we're really going to zero in on gynecology. We're aiming to pull out all the super high yield stuff you'll need for your shelf and Step2CK exams.
Exactly. We've got a bunch of notes here, and the plan is to walk through them using, realistic clinical vignettes.
Right. The idea is to help you make those strong connections for diagnosis and treatment. It's all about making it stick for the exams.
Precisely. Think of it as a focused review. We'll hit a lot of key areas, the menstrual cycle, GYN cancers, infections, all that stuff, but framed like you'd see it in clinic or on the test.
Okay, awesome. Let's jump right in then. Let's start with the menstrual cycle and some related issues. So picture this. A woman, maybe late 40s, comes in. Her periods are all over the place. She can't sleep, and she's having these really annoying hot flashes. What's the first thought?
Yeah, that picture, it really screams perimenopause.
Perimenopause.
Yeah. The key thing here is those fluctuating hormones in the late 40s. That's what drives this transition phase. You get the irregular cycles, the vasomotor symptoms, and it can start years before actual menopause. Important point. She can still ovulate sometimes, even with these changes.
Good point. Okay, so now let's shift. Imagine a woman, she's over 45, and she tells you she hasn't had a period for like a full year.
Yeah.
12 months straight. What's the diagnosis now, and what are the big consequences we need to think about?
Right, 12 months of amenorrhea over 45. That's pretty much the definition of menopause.
Okay.
It means her ovaries have essentially stopped working, leading to low estrogen levels, hypoestrogenemia. And that low estrogen, well, it causes a cascade of things. You get those vasomotor symptoms again, like hot flashes, sleep problems.
Yeah.
But also vulvovaginal atrophy, which can make intercourse painful, and a higher risk for osteoporosis down the line.
Okay.
Oh, and critically, you always want to rule out other things, especially thyroid problems, because they can mimic some symptoms.
Good call. And you mentioned confirming it. What about FSH levels?
Yeah, FSH can be helpful sometimes. Yeah. Like if someone's had a hysterectomy and an ablation, the no periods for 12 months rule doesn't quite work. In those cases, a high FSH level, typically in the postmenopausal range, can help confirm it.
Got it. So those hot flashes can be pretty miserable. How do we tackle those?
Well, it depends on severity. For milder symptoms, lifestyle stuff might be enough, dressing in layers, maybe some weight loss if needed.
Okay.
But if they're severe, really impacting her life, then hormone replacement therapy, HRT, is an option. But there are rules there. She needs to be under 60 and within 10 years of menopause starting.
And there are contraindications too, right?
Absolutely. Big ones, history of heart disease, blood clots like VTE, TIA, or stroke, or breast or endometrial cancer. Those are definite no-goes for HRT.
So if HRT is out, what then?
SSRIs. Certain antidepressants like SSRIs can actually help manage hot flashes pretty well. So that's a good alternative if HRT isn't safe.
Interesting. Okay, let's talk more about that low estrogen effect, especially on the genitourinary system. So a postmenopausal woman comes in, she's got vaginal dryness, sex is painful dyspareunia, and she keeps getting UTIs. What's going on there?
That's a classic picture of atrophic vaginitis, or what we now often call the genitourinary syndrome of menopause, GSM.
GSM, okay.
Yeah. The estrogen drop causes thinning of the vulvar and vaginal tissues. The vaginal opening, the introitus, can narrow, and natural lubrication decreases a lot.
Makes sense.
And there's another piece. Less estrogen means less glycogen in the vaginal cells. Glycogen feeds the good bacteria, the lactobacilli. So you lose those, the vaginal pH goes up, and that makes you more prone to UTIs.
Ah, okay. So that explains the recurrent UTIs.
Exactly. Plus, the bladder and urethra have estrogen receptors too, so women can get urinary symptoms like urgency, incontinence, or painful urination, dysuria. On exam, you might see the tissues look pale, thin, maybe easily irritated or bleed a bit.
So how do we treat this GSM?
Start simple. Non-hormonal lubricants and moisturizers are first line for the dryness and painful sex.
Okay.
But if that's not enough, or symptoms are more severe, topical vaginal estrogen works really well. It directly targets the tissues and reverses a lot of those atrophic changes.
And you mentioned differentiating it from other things.
Right, you got to keep other vulvar conditions in mind. Like lichen planus might have lesions, but they often look purplish, maybe with white lines called Wickham striae. And it doesn't usually cause dryness itself.
Okay.
Lichen sclerosus gives you thin, white, wrinkled skin, often itchy, and can involve the area around the anus, but again, doesn't directly impact vaginal moisture.
Gotcha. And vulvodynia.
That's different again. Vulvodynia is mainly pain, sharp, burning pain, usually on touch, often around the vaginal opening. You might see some redness, but not the tissue thinning or narrowing you see with atrophy.
That's super helpful. Okay, let's focus on vulvar lichen sclerosis then. Who typically gets this, and what are the key things to look for?
We see lichen sclerosis most often in two groups: prepubertal girls and postmenopausal women.
Interesting, okay.
The classic look is thin, wrinkled, whitish hypopigmented skin on the vulva. And the main symptom is usually intense itching, pruritus. Over time, it can really change the anatomy. The labia minora might shrink or disappear. The clitoral hood can get scarred down. This leads to a narrowing of the vaginal opening, so sex becomes painful. Urination can be painful too.
And you mentioned perianal involvement.
Yes, that's common.
Okay.
It can cause pain with bowel movements, even anal fissures sometimes.
So if you suspect lichen sclerosis, what's the workup and treatment?
Diagnosis really needs a biopsy, a punch biopsy of the affected skin. That confirms it, but crucially, it also rules out vulvar cancer. There's an increased risk of squamous cell carcinoma in long-standing lichen sclerosis.
Right, biopsy is key. And treatment.
First-line treatment is a super potent topical corticosteroid like levetosol that helps control the inflammation and the itching.
And how does this differ from, say, lichen simplex chronicus?
Lichen simplex chronicus is basically thickened, leathery skin that develops from chronic scratching or rubbing. It's a response to itch, rather than the primary inflammatory process you see in lichen sclerosis. And perianal strep dermatitis is different. Again, that's a bacterial infection causing a bright red, sharply defined rash around the anus, often with itching and fissures.
Okay. And just quickly, circling back to vulvar cancer, what are the main red flags and risk factors?
Risk factors include persistent high-risk HPV infection, chronic vulvar inflammation like lichen sclerosis, smoking is a big one, and a history of vulvar intraepithelial neoplasia. Clinically, you'd worry about persistent itching that doesn't get better, a visible lump, plaque, or ulcer on the vulva, or any abnormal bleeding or discharge. Biopsy of any suspicious lesion is how you diagnose it.
Got it. And perianal strep dermatitis, key finding.
Bright red rash, sharp borders right around the anus, often itchy, maybe some fissures. Think strep.
Okay, big shift now. Let's talk legal stuff for a second. Emancipated minors. When can a minor actually consent for their own health care?
Right, this is important. Generally, minors gain the ability to consent in a few specific situations. Key insight. Emergencies are one. Treatment for STIs is another big one. Mental health and substance abuse treatment often allows minor consent. And then anything related to pregnancy care, including contraception.
So it's context dependent.
Exactly. It can be through formal legal emancipation, like getting married or joining the military, or through what's called medical emancipation, where the specific type of care, like STI treatment, allows them to consent on their own behalf by law.
Okay, that's a useful distinction. Let's move into STIs now. There are several that cause genital ulcers.
Yeah.
How do we start telling them apart clinically?
Yeah, the ulcer characteristics are really helpful. You want to look at a few things. How many ulcers are there, single or multiple? How deep are they? What does the base look like? Is it clean? Is it full of pus? Is it hard? And importantly, is it painful?
Pain seems like a big one.
It often is. For example, chancroid, caused by Haemophilus ducreyi, usually gives you multiple deep ulcers that are very painful, often with a gray or yellow exudate at the base.
Okay. What about herpes?
Genital herpes from HSV typically starts as small blisters, vesicles, often in a group on a red base. These break open to form shallow ulcers, and they are usually quite painful too. You might get some swollen lymph nodes nearby.
And syphilis.
Primary syphilis, the classic presentation, is a single ulcer called a chancre. It's typically painless, and the base feels firm or hard, indurated.
Painless, single, hard base, think syphilis. Got it. LVG.
Lymphogranuloma venereum, which is caused by certain types of chlamydia trachomatis, often starts with a small, painless ulcer that might even go unnoticed. The key feature comes later, painful, swollen lymph nodes in the groin, called buboes.
And one more, granuloma inguinale.
Less common in some areas, but it causes these progressive, beefy red, often painless ulcers that look like granulation tissue, caused by Klebsiella granulatus.
Okay, so pain, number, depth, base, those are the keys for ulcers. Now let's talk about the really common ones, especially in younger women. Gonorrhea and chlamydia. What's crucial to remember?
Number one thing, they are often asymptomatic, especially chlamydia. That's why screening is so important.
Right, who gets screened?
Key insight. Annual screening for both gonorrhea and chlamydia using NIT testing is recommended for all sexually active women under 25. Also for women 25 and older, if they have risk factors like new or multiple partners, or not using condoms consistently.
And if they do have symptoms?
It can cause cervicitis, inflammation of the cervix, maybe with discharge. urethritis, inflammation of the urethra, and sometimes it can spread up and cause perihepatitis, inflammation around the liver capsule. That's Fitzhugh-Curtis syndrome. Gives you right upper quadrant pain.
How are they typically treated, and what happens if they're missed?
Because they're so common and can have serious consequences, we often treat empirically while waiting for test results. The usual go-to is combination therapy to cover both, often ceftriaxone injection plus oral azithromycin. If you confirm it's only chlamydia, then azithromycin alone might be enough. If it's confirmed gonorrhea, you definitely need the combo ceftriaxone plus azithromycin because of resistance issues with gonorrhea.
And the complications if untreated?
Big ones.
Huh.
Pelvic inflammatory disease, PID, is the major one. That can lead to chronic pelvic pain, ectopic pregnancy down the road, and infertility. And you can also get pharyngitis from oral sex transmission.
Okay. Let's circle back to syphilis. That primary chancre, what else should we know about it?
Right, the chancre, it pops up where the bacteria entered, usually 3 to maybe 60 days after exposure. Key point, it's painless, single, hard base, like we said, highly infectious. But here's the tricky part. It heals on its own, usually in a few weeks, even without treatment.
Ah, so the person might think it's gone.
Exactly. But the infection hasn't gone anywhere. It's become systemic and will progress to secondary and later stages if not treated.
So how do we diagnose and treat it then?
Diagnosis is mainly through blood tests, serology. You have the non-troponemal tests like RPR, VBRL. These give you a titer, a number that usually goes up with infection and down with treatment. But they can be falsely negative really early on.
Okay.
Then you have the troponemal tests like FTA-ABS or TPEIA. These detect antibodies specifically against the syphilis bacteria. They're usually positive earlier and tend to stay positive for life, even after treatment. So they confirm the diagnosis, but you use the RPR-VDRL titer to monitor treatment response.
And treatment if you strongly suspect it, but tests are pending or negative early.
If you have a classic chancre, the recommendation is to treat empirically right away with a shot of long-acting penicillin G, benzathine penicillin G. Don't wait for serology if the suspicion is high. Then you repeat the RPR-VDRL in a few weeks to get a baseline titer to follow.
Okay, makes sense. Now, a really difficult but vital topic, sexual assault evaluation. What are the absolute key components of the initial medical care?
It requires a very careful, compassionate approach. There are several parts. First, the medical and forensic exam. That involves documenting any injuries, collecting evidence like swabs for DNA, clothing, hair samples, all done meticulously.
Right.
Equally important is the psychological assessment, addressing the immediate trauma, screening for distress, and figuring out what support they might need long-term. PTSD, anxiety, depression are unfortunately common consequences.
And the immediate medical management, what do we need to offer?
Several things. We need to address the risk of unintended pregnancy and STIs. So offering emergency contraception is crucial if that's desired. And then post-exposure prophylaxis, or PP, for STIs.
What does PP typically cover?
It covers the most likely infections. Usually azithromycin for chlamydia, ceftriaxone for gonorrhea, and metronidazole for trichomonas. We also need to assess HIV risk and offer HIV PEP if indicated. That's usually a combination drug regimen started ideally within 72 hours. And hepatitis B status is assessed. They might need the vaccine, immunoglobulin, or both, depending on their history, and the assailant status if known. Plus, connecting them to counseling and support services is vital.
Okay. Let's shift gears to urinary tract issues. Basic UTIs, we know E. coli is the usual culprit, ascending infection, classic symptoms like dysuria, frequency. Anything specific to highlight in the GYN context?
Well, the proximity of the urethra to the vagina is key, obviously. And factors like sexual activity can increase risk. Diagnosis is usually clinical, plus urinalysis showing pyuria and bacteria, standard antibiotic treatment. Pretty straightforward usually.
What about recurrent UTIs? How are those defined and managed?
Recurrent UTIs are typically defined as 2 or more infections in 6 months or 3 or more in a year. Risk factors include being sexually active, being postmenopausal due to estrogen changes affecting the tissues, having your first UTI at a young age, like under 15, and using spermicides can also increase risk.
And prevention.
Key insight. Prevention strategies can include lifestyle stuff, hydration, voiding habits, but for women with frequent recurrences, especially if they're linked to sex, antibiotic prophylaxis is often used. That could be a low dose daily or a single dose taken right after intercourse postcoital prophylaxis.
Got it. Okay, let's talk about abnormal uterine bleeding, AUB. Very common complaint. How do we define it, and what are some classic patterns that point to different causes?
Right. AUB is basically any bleeding that's outside the norm for that woman frequency, duration, amount. So bleeding lasting more than, say, 5 to 7 days, bleeding that's super heavy, like soaking through pads every hour or two, or bleeding between
And
periods.
causes, like if someone has really heavy periods and maybe constipation or urinary frequency.
Heavy bleeding, plus those bulk symptoms, difficulty peeing or pooping, feeling pelvic pressure or heaviness, and you feel an enlarged uterus on exam. That really points towards uterine fibroids, leiomyomas.
Okay, what if the main complaint is super painful periods plus heavy bleeding, and the uterus feels kind of boggy and tender?
Painful periods, dysmenorrhea plus heavy bleeding, and a uterus that feels symmetrically enlarged, maybe globular or boggy and tender. Think adenomyosis, that's endometrial tissue growing into the muscle wall of the uterus.
And what about irregular bleeding, bleeding between periods or any bleeding after menopause, especially with risk factors like obesity?
Irregular bleeding, intramenstrual bleeding, or any postmenopausal bleeding, especially if the woman has risk factors like obesity, never having children, chronic anovulation like in PCOS, and the uterus feels normal or non-tender. That pattern should raise your suspicion for endometrial hyperplasia or even endometrial cancer. Needs investigation.
Okay. There are a lot of diagnostic tools in GYM. Let's run through some key indications for imaging or biopsies. When is a breast MRI typically used?
Breast MRI isn't for routine screening. It's usually reserved for specific things. Looking at the extent of known breast cancer, screening women at very high risk like BRCA mutation carriers, or maybe clarifying confusing findings from a mammogram or ultrasound.
And mammography.
Mammography is the main screening tool for breast cancer, generally starting for average risk women over 30 or 40 or 50, depending on guidelines, but definitely indicated for evaluation of symptoms in women over 30.
What about a core biopsy of the breast?
You do a core biopsy for a suspicious palpable mass or a concerning finding on imaging.
Hmm.
Also for breast cysts that aren't simple, like if they're complex, come back after being drained or have solid bits inside.
Got it. And endometrial biopsy, we touched on this with AUB, but can you list the main indications again?
Sure. Endometrial biopsy is really important. Key indications. Any postmenopausal bleeding, period. AUB in women over 45. AUB in women under 45. IF, they have risk factors like unopposed estrogen, obesity, PCOS, if medical treatment failed, if bleeding's been going on for over 6 months, if they're on tamoxifen, or if they have a thickened endometrial stripe on ultrasound along with an ovarian mass.
Okay.
Also finding endometrial cells on a pap test in a postmenopausal woman or sometimes in a premenopausal woman with AUB and risk factors.
What about the progesterone withdrawal test?
That's used to evaluate secondary amenorrhea.
Yeah.
You give progesterone, then stop it. If she bleeds, it means her endometrium was primed by estrogen, so her estrogen levels are likely adequate. If she doesn't bleed, it suggests low estrogen is the problem.
And any procedures where undiagnosed AUB is a contraindication?
Yeah, you generally wouldn't do an endometrial ablation or a hysterosalpingogram if someone has undiagnosed AUB because you need to rule out cancer or hyperplasia first.
Bro.
And one more thing, if you find congenital abnormalities of the uterus or vagina, always get a renal ultrasound. Kidney and reproductive tract development are linked embryologically.
Good point. Okay, shifting to fertility, clomiphene citrate, common drug. How does it work?
Clomiphene is a selective estrogen receptor modulator, a SERM. Key insight. It works mainly at the hypothalamus. It blocks estrogen receptors there, tricking the brain into thinking estrogen levels are low.
Okay.
So the hypothalamus kicks out more GnRH, which tells the pituitary to release more FSH and LH. That extra FSH stimulates the ovaries to develop follicles, hopefully leading to ovulation, used for women who aren't ovulating regularly.
And HCG, human chorionic gonadotropin, what's its role?
HCG is the pregnancy hormone, right?
Yeah.
Produced by the early placenta, the syncytiotrophoblast. Key insight. Its main job early on is to keep the corpus luteum alive and producing progesterone, which maintains the uterine lining until the placenta takes over around 6 to 8 weeks.
That's why the levels rise so fast.
Exactly. They typically double about every 48 hours in early viable pregnancy. It also has roles in male fetal development and can slightly stimulate the mom's thyroid. And we use it in fertility treatments, too, to trigger ovulation after stimulating the follicles.
Okay. Now, what if a pap test comes back showing atypical glandular cells, AGC? What's the workup?
AGC is a concerning finding because it could indicate abnormalities higher up in the endocervical canal or even in the endometrium. So the workup needs to evaluate all those areas. That means colposcopy to look closely at the cervix, endocervical curetage, ECC, to sample the canal, and an endometrial biopsy, EMB, to check the uterine lining.
Gotta check everywhere. Okay. Scenario. Postmenopausal woman, new ovarian mass found on imaging. What are we thinking about? What are the big risk factors for ovarian cancer?
Yeah, postmenopausal ovarian mass always raises concern for malignancy. Key risk factors for epithelial ovarian cancer include increasing age, family history, especially ovarian, breast, colon cancer, think BRCA or Lynch syndrome, never having children, null gravidity, maybe fertility drug use, endometriosis, and early menarche or late menopause.
And how do we assess the risk initially?
Usually starts with a good pelvic ultrasound to really look at the mass size. Is it cystic, solid, complex? Are there septations? Is there sites? And we measure a serum CA-125 level.
CA-125, how useful is that?
It's more specific for ovarian cancer in postmenopausal women. In premenopausal women, lots of benign things can raise it. So in postmenopausal women, the ultrasound findings plus the CA-125 level help stratify the risk.
What's the management approach based on that risk?
If the ultrasound looks suspicious solid parts, thick walls, sites, or the CA-125 is high, you'll likely need more imaging, maybe CT or MRI, and usually surgical evaluation. If it looks benign on ultrasound, like a small, simple cyst, and the CA-125 is normal, you might monitor with repeat ultrasounds. Key insight. Critically, you do not want to just stick a needle in and aspirate a suspicious ovarian mass in a postmenopausal woman. High risk of seeding cancer cells if it is malignant.
Right, no aspiration. Let's talk more about epithelial ovarian carcinoma itself. How does it typically present?
It's often subtle, unfortunately, especially early on. Some women are asymptomatic, found incidentally. Others have vague subacute symptoms, maybe some pelvic or abdominal pain, bloating, feeling full quickly when eating, changes in bowel or bladder habits. Advanced disease can cause more acute things like significant belly swelling from ascites, trouble breathing if fluid builds up in the chest, or even bowel obstruction.
And risk factors versus protective factors.
We mentioned risk factors: age, family history, genetics like BRCA, nulliparity, maybe HRT, endometriosis. Protective factors are things that reduce ovulation. So using oral contraceptive pills, having multiple pregnancies, breastfeeding, these all lower the risk.
What about lab and imaging findings and the general treatment plan?
Lab-wise, CA-125 is often elevated, but not always. Ultrasound usually shows a complex adnexal mass, maybe solid areas, thick septations, papillary projections, ascites septets, but definitive diagnosis and staging require surgery. Management is primarily surgical, aiming to remove all visible tumor, called site reduction, followed by chemotherapy.
Okay.
And again, image-guided biopsy is generally a no-no due to seeding risk.
Got it. Beyond epithelial ovarian cancer, there are other types. Are there specific tumor markers associated with some of those?
Yes, definitely. Different tumor types can produce different markers. For germ cell tumors, like this germinoma, you might see elevated HCG and LDH. Yolk sac tumors often produce AFP, alpha-fetoprotein. For sex cord stromal tumors, granulosa cell tumors typically make lots of estradiol and inhibin, and Sertoli-Leydig cell tumors often produce androgens like testosterone. These markers can be really helpful for diagnosis and monitoring.
Okay, excellent. Let's move into endocrine disorders that affect GYN health. What about aromatase deficiency? What does that look like?
Aromatase deficiency is rare. Its genetic can't convert androgens to estrogens. Key insight. So someone with a 46XX karyotype will have normal internal female organs, uterus, tubes, because that development doesn't need estrogen. But externally, they'll be virilized at birth because of the unopposed androgens. The mother might even show some virilization during pregnancy. Later in adolescence, they'll have delayed puberty, no breast development, primary amenorrhea, osteoporosis risk from low estrogen, and high FSH/LH levels. Ovaries might look polycystic.
Okay. And a Sertoli-Leydig cell tumor of the ovary. What's the classic presentation?
These are ovarian tumors that pump out androgens, mostly testosterone. Key insight. The hallmark is rapid onset hyperandrogenism and virilization, usually developing over less than a year. So, think worsening hirsutism, male pattern hair loss, maybe deepening voice, clitoromegaly, increased muscle mass, acne.
And what about estrogen levels?
Because the high androgens suppress the normal HPO axis, estrogen levels often drop. So they might also get symptoms of estrogen deficiency like breast atrophy, vaginal dryness, painful sex, and irregular periods or no periods at all.
How do you diagnose and manage that?
You check hormone levels. Testosterone will be markedly high, usually over 150 NGDL. DHEAS, which comes from the adrenals, will typically be normal or only slightly up. If DHEAS is super high, like over 700 milli-TGDL, you think adrenal tumor instead. Pelvic ultrasound or MRI helps find the ovarian mass. Treatment is surgery to remove the affected ovary. That's diagnostic and therapeutic.
Got it. So, thinking about hirsutism more broadly, what are the common culprits we need to differentiate?
Most common cause is PCOS, polycystic ovary syndrome. associated with irregular periods, androgen excess signs, often obesity, insulin resistance. Then there's idiopathic hirsutism, just the hair, but periods and hormones are normal. Non-classic congenital adrenal hyperplasia, late-onset CAH, can mimic PCOS. Check a 17-hydroxyprogesterone level. Androgen-secreting tumors, like the Sertoli-Leydig we just discussed, cause rapid, severe symptoms. Ovarian hypertrichosis is similar but more common postmenopausally. And don't forget Cushing's syndrome, look for central obesity, moon phases, striae, along with hirsutism.
And just to summarize, the main signs suggesting hyperandrogenism.
Hirsutism, that male pattern hair, severe or persistent nodular cystic acne, and androgenic alopecia, hair thinning, especially at the temples and crown. If you see those, you run through that differential diagnosis we just talked about.
Okay. Ectopic pregnancy, another critical topic. What's the key ultrasound finding that helps rule it out early on?
Seeing an intraproterine pregnancy, a gestational sac, with a yolk sac or fetal pole inside the uterus on a transvaginal ultrasound, that pretty much rules out ectopic. Key insight. You should reliably see that intraproterine sac when the serum HHCG level hits a certain point, the discriminatory zone, usually around 1500 to 2000 IUL. If the HHCG is above that level and you don't see anything in the uterus, ectopic is highly likely.
And the general management approach for suspected ectopic?
Depends if the patient is stable or unstable. If he's hemodynamically stable, you start with the transvaginal ultrasound. If you see an intraproterine pregnancy, great. If you see an adnexal mass suggesting ectopic, or if the ultrasound is non-diagnostic, you check the SHTG. If it's below the discriminatory zone, repeat it in 48 hours. See if it's rising appropriately for intrauterine or abnormally suggesting ectopic or non-viable pregnancy. If it's above the zone with no intraproterine pregnancy seen, that points strongly to ectopic.
And if she's unstable?
Unstable patient signs of shock, severe pains suggesting rupture needs immediate surgical consultation. No time to waste. After treatment, whether medical, with methotrexate, or surgical, you need to follow serial HCG levels down to 0 to make sure it's fully resolved.
Right. Let's talk HPV human papillomavirus vaccination recommendations.
Routine vaccination starts around age 11 or 12 for both boys and girls. It can start as early as 9. Key insight. Catch-up vaccination is recommended through age 26 for females and through age 21 for males who weren't vaccinated earlier. And for certain groups like men who have sex with men or immunocompromised individuals, catch-up is recommended through age 26. It protects against the HPV types most likely to cause cancer and genital warts.
And genital warts themselves, condyloma acuminata, how are they treated?
Lots of options. Patient can apply creams at home, like imiquimod or Potifilox, or the provider can do treatments in the office, like cryotherapy, freezing, applying trichloroacetic acid, TCA, or surgical removal or laser. Choice depends on the wart size, number, location, and patient preference. Important. Treatment gets rid of the warts you see, but doesn't cure the underlying HPV infection.
We know persistent high-risk HPV causes cervical cancer. Can you just briefly trace that path and mention other HPV-related cancers?
Sure. Persistent infection with high-risk types, especially HPV 16 and 18, can cause precancerous changes in the cervix called cervical intraepithelial neoplasia, or CIN, grading CIN 1, 2, or 3. Key insight. High-grade lesions, CIN 2 and 3, if left untreated, can progress over years to invasive cervical cancer. Low-risk types, like 6 and 11, cause most genital warts. The vaccine covers the main high-risk and low-risk types.
Okay. And anything else important about managing condyloma?
Just to reiterate, they're benign growths from low-risk HPV 6 and 11. Can look like small, flat bumps or bigger cauliflower shapes, pink or skin-colored. Can be on vulva, vagina, cervix, penis, scrotum, around the anus. Treatment options we discuss: chemical, immune-based, or physical removal. Prevention is key. Vaccination and barrier contraception help reduce spread.
The PAP test, cornerstone of screening. What are the current guidelines? When to start, how often, when to stop?
Okay? For average-risk immunocompetent women, screening starts at age 21 with a PAP test every 3 years. Key insight. We generally don't do HPV testing routinely under age 30. Why? Because HPV is super common then and usually clears on its own, so testing leads to a lot of unnecessary worry and procedures.
Makes sense. What about age 30 and up?
From 30 to 65, the preferred method is co-testing, doing both a PAP test and an HPV test every 5 years. Or PAP test alone every 3 years is still acceptable.
And when can screening stop?
Usually after age 65, if she's had adequate negative prior screening, like 3 negative PAPs or 2 negative co-tests in the last 10 years. A&D, no history of CIN2 or higher. If she has had CIN2 or higher, screening should continue for at least 20 years after that diagnosis, even if it goes past 65. And you don't stop just because of age. If someone is immunosuppressed or had DES exposure in utero.
Are there specific PAP findings that trigger needing an endometrial sample too?
Yes. In postmenopausal women, any endometrial cells found on a Pap test warrant an endometrial biopsy. In premenopausal women, benign endometrial cells are usually okay unless she has AUB or risk factors. But the big one is atypical glandular cells, AGC. If AGC is found, especially if it says favor neoplastic, you need that full workup we talked about earlier, colposcopy, ECC, and endometrial biopsy, especially if she's 35 or older or has risk factors.
Got it. Okay, let's switch to a serious pregnancy complication, HELLP syndrome. Defining features.
HELLP is an acronym. H for hemolysis, EL for elevated liver enzymes, LP for low platelets. It's often considered a severe variant of preeclampsia. Clinically, women might have right upper quadrant or epigastric pain, nausea, vomiting, maybe headache or vision changes.
And the underlying cause, what's happening?
It's thought to stem from abnormal placentation. This leads to endothelial damage, inflammation throughout the body. The coagulation system gets activated, platelets get consumed, hence the low platelets. You get microclots forming, especially in the liver, causing liver damage in the elevated enzymes. And red blood cells get damaged, squeezing through these clogged small vessels, leading to hemolysis.
How do we manage HELLP?
It's serious. The main goals are to stabilize the mother and deliver the baby. Stabilization means controlling high blood pressure with antihypertensives and giving magnesium sulfate to prevent seizures. Key insight. Delivery is the definitive cure. Timing depends on gestational age and how sick mom and baby are. Generally, deliver if 34 weeks or at any age if there's fetal distress or mom's condition is worsening rapidly.
Okay. What about lactational amenorrhea, that natural postpartum contraception? How does it work?
Right. It's temporary infertility while exclusively breastfeeding. Key insight. The high prolactin levels needed for milk production suppress GnRH release from the hypothalamus. No GnRH means low FSH and LH from the pituitary, so the ovaries don't ovulate and she doesn't menstruate.
How effective is it?
It can be quite effective, like 98%, but only under specific conditions. She has to be exclusively breastfeeding, on demand, day and night, her periods haven't returned, and she's less than 6 months postpartum. As soon as any of those change, baby starts solids, periods return, it hits 6 months, she needs another form of contraception. Ovulation can return before the first period.
Good to know. Okay, the HPO axis, hyperthalamic pituitary ovarian axis. Quick refresher for exams.
Simple framework. Hypothalamus makes GnRH impulses. GnRH tells the pituitary to make FSH and LH. FSH grows the follicles in the ovary, which make estrogen. LH triggers ovulation and supports the corpus luteum, which makes progesterone. Then estrogen and progesterone feed back to the hypothalamus and pituitary to control the whole cycle. It's a feedback loop.
Got it. And normal puberty in girls, typical sequence and timing.
Starts usually between 8 and 13. First sign is typically breast budding, the Delarge, Tanner stage 2. Then pubic hair appears pubarch, then the big growth spurt. And finally, menarche, the first period usually happens about 2 to 2.5 years after breast buds start, typically between 10 and 16. The whole process takes about 45 years.
And Tanner stages just help classify that visually?
Exactly. 5 stages for breast development, 5 for pubic hair. Stage 1 is prepubertal. Stage 5 is fully mature adult. It's just a standardized way to track development.
Okay. Primary dysmenorrhea, painful periods without underlying disease. What's the classic picture?
Very common in teens and young women. Usually starts within a few years of menarche. It's that crampy lower abdominal pain, often radiating to the back or thighs. Starts just before or with the period, lasts a few hours to maybe 2-3 days. Caused by prostaglandins released from the shedding endometrium that make the uterus contract strongly.
Any other symptoms?
Yeah, it can have nausea, vomiting, diarrhea, fatigue, headache sometimes. But the key is a normal pelvic exam. Often gets better with age or after having kids.
Any risk factors? And treatment?
Risk factors include younger age, low BMI, smoking, early menarche, heavy periods. Treatment. First line is NSAIDs. They block prostaglandin production. If she's sexually active and wants contraception, combination OCPs are great. They suppress ovulation and reduce prostaglandin production.
And secondary dysmenorrhea, when do we suspect that?
Secondary dysmenorrhea means there is an underlying pelvic problem causing the pain. Suspected if the pain starts later in life, say after 25, if it's unilateral, not midline cramping, if there are other symptoms like pain outside of her period, heavy irregular bleeding, pain with sex or bowel movements, or if the pelvic exam is abnormal, enlarged uterus, tenderness, masses. Think endometriosis, adenomyosis, fibroids, PID.
Okay. Pelvic organ prolapse, POP. Basic definition and a common symptom.
POP is when pelvic organs bladder, uterus, rectum drop down into the vagina because the supporting muscles and ligaments are weak. A common symptom patients describe is a feeling of vaginal pressure, heaviness, or like something is bulging or falling out, especially with standing or straining. Sometimes they can actually see or feel a bulge. Uterine prostatitia is when the uterus itself drops way down.
What kinds of symptoms might they have?
Depends on what's prolapsing and how bad it is. Vaginal pressure or bulge feeling is common. Urinary issues like frequency, urgency, incontinence, or trouble emptying the bladder. Bowel problems like constipation or feeling like you can't fully evacuate. Lower backache, painful sex. But mild prolapse might have no symptoms at all.
When do we treat it, and what are the options?
Treatment is usually only needed if it's causing bothersome symptoms that affect quality of life. If asymptomatic, just observe. Options: lifestyle changes like weight loss, pelvic floor exercises, Kegels, vaginal pessaries devices inserted to support the organs, and then surgery to repair the supports using native tissue or sometimes mesh. Different types depending on what prolapse: cystocele, bladder, rectocele, rectum, uterine prolapse, etc. Risk factors include age, having babies vaginally, obesity, chronic cough, or constipation.
Okay. And premenstrual syndrome, PMS diagnosis and management.
PMS involves recurrent physical and mood symptoms that happen in the luteal phase the week or two before the period and resolve once the period starts. Key insight for diagnosis: needs to be cyclical and impact daily life. A symptom diary kept over at least 2 cycles is crucial to confirm the timing and pattern. Management: lifestyle first, exercise, stress reduction, maybe dietary changes like less caffeine salt. For mood symptoms, SSRIs can be very effective. For physical symptoms, OCPs can help. NSAIDs for pain. Treatment is tailored to the symptoms. Note: OCPs usually aren't ideal if she has migraines with aura.
Right. Okay, let's move to specific GYN tumors, starting with granulosa cell tumors. What are their key clinical effects?
Granulosa cell tumors are ovarian sex cord stromal tumors. They're often hormonally active, producing estrogen and inhibin. Key insight: that excess estrogen is the issue. In kids, it can cause precocious puberty. In reproductive age women, irregular bleeding. In postmenopausal women, it can cause endometrial hyperplasia and significantly increases the risk of endometrial cancer. So any postmenopausal bleeding with one of these needs an endometrial biopsy.
How are they evaluated and treated?
Ulphic exam, ultrasound, or other imaging to see the ovarian mass. Check serum estradiol and inhibin levels, useful for diagnosis and monitoring recurrence. Endometrial biopsy, if there's bleeding. Treatment is surgery, usually removing the affected ovary and tube, salpingo-oophorectomy. If it's early stage and she wants fertility, maybe just unilateral surgery. If it's advanced or there's endometrial cancer, then full hysterectomy and bilateral salpingo-oophorectomy with staging. Ablation is contraindicated if cancer is present. Follow-up often includes tracking inhibin levels.
Okay. What about choriocarcinoma? What is it, and how does it present?
Choriocarcinoma is a malignant type of gestational trophoblastic disease, GTD. It can happen after any pregnancy, molar, normal, abortion, ectopic. Key insight: it grows fast and spreads widely, usually through the bloodstream. Often presents within 6 months of the pregnancy with irregular vaginal bleeding, maybe enlarged uterus, pelvic pain. Because it metastasizes early, common sites are lungs, chest pain, cough, shortness of breath, vagina bleeding, nodules, brain, liver. Beta-HCG levels are usually very high.
Diagnosis and treatment.
Diagnosis relies on those high or rising ACE-HCG levels after a pregnancy, plus imaging to look for uterine tumor and metastases. Chest x-ray is important. Sometimes histology from curettage helps. Treatment is primarily chemotherapy. It's very chemosensitive. Regimen depends on risk factors. Surgery, hysterectomy might be used sometimes. Risk factors include older maternal age and prior molar pregnancy.
Let's talk about fistulas. Rectovaginal fistula, what is it? Main causes.
A rectovaginal fistula is an abnormal connection between the rectum and the vagina. Stool or gas passes into the vagina. Key insight: in developed countries, the most common cause by far is obstetric injury during childbirth, specifically severe perineal tears, 3rd or 4th degree, that aren't repaired well, break down, or get infected. Other causes: pelvic surgery complications, Crohn's disease, radiation, cancer. In less developed areas, prolonged obstructed labor is a major cause. It usually shows up in the first few weeks postpartum or after surgery.
Symptoms, diagnosis, treatment.
Main symptom is passing stool or gas through the vagina, or foul-smelling discharge. Can cause infections, irritation. Diagnosis is often just by seeing the opening on pelvic exam, maybe on the posterior vaginal wall. Dye tests or imaging can help if needed. Treatment is surgical repair.
And similarly, vesicovaginal fistula. Risk factors.
Vesicovaginal fistula is a connection between the bladder and vagina. Urine leaks continuously into the vagina. Key risk factors in developed countries are pelvic surgery complications, especially hysterectomy, and pelvic radiation. Prolonged obstructed labor is a big factor worldwide. Less common, trauma, advanced pelvic cancers. Presentation is painless, continuous urine leakage from the vagina.
Diagnosis and treatment.
History is suggestive. Exam might show the fistula. Dye test and still dye in bladder, look for it in vagina, confirms it. Cystoscopy helps visualize the bladder side. Treatment is surgical repair.
Okay, back to cervical cancer. We covered HPV, other risk factors, clinical presentation.
Other risks besides high-risk HPV include history of other STIs, starting sex young, multiple partners, immunosuppression like HIV, long-term OCP use, small risk, smoking, lower socioeconomic status. Key insight, often asymptomatic early on. If symptoms occur, it might be abnormal discharge, watery, bloody, smelly, bleeding after sex, bleeding between periods. Advanced stages cause pain, leg swelling, urinary rectal issues. Seeing a lesion on the cervix is a big red flag.
Diagnosis recap.
Starts with Pap test. Abnormal Pap leads to colposcopy, magnified view of cervix, with biopsies of any suspicious areas. Maybe endocervical curettage if needed. Histology confirms the diagnosis.
And if someone has CIN3 high-grade dysplasia, management.
CIN3 needs treatment to remove the abnormal cells, usually loop electrosurgical excision procedure, or cold knife conization. Tissue goes to pathology to check the margins. If margins are positive, abnormal cells at the edge, and she wants fertility, maybe repeat conization. If fertility isn't desired or margins stay positive, hysterectomy might be needed. If margins are negative, follow-up is close monitoring with PAP-HPV co-testing at 1 and 2 years.
Any special considerations for HIV-positive women?
Yes. Cervical cancer is actually an AIDS-defining illness because HPV progresses much faster to cancer when the immune system is weak. Key insight. So screening needs to be more frequent. Start PAP at HIV diagnosis, then repeat maybe every 6-12 months depending on results. Manage it at dysplasia might also be more aggressive.
Okay. Primary ovarian insufficiency, POI. Definition and diagnosis.
POI is when the ovaries stop working properly before age 40. Leads to low estrogen, irregular or absent periods, amenorrhea, diagnostic criteria, amenorrhea for at least 3 months, plus high FSH levels, usually 40 MIU/mL, on 2 tests at least a month apart. Need to rule out pregnancy, thyroid issues first.
Management. And what causes it?
Management focuses on replacing estrogen with HRT, helps symptoms, hot flashes, dryness, and protects bones and heart. Fertility usually requires donor eggs, though cryopreservation beforehand might be an option if the cause was known, like prior to chemo. Causes can be genetic, Turner syndrome, Fragile X premutation, autoimmune attack on the ovaries, damage from chemo or radiation, surgery infections, metabolic disorders like galactosemia. Often the cause is unknown, idiopathic. Important to distinguish from hypothalamic amenorrhea that also has low estrogen, but FSH, LH are low or normal, not high, and often no hot flashes.
Right, hypothalamic amenorrhea, common causes.
Usually related to stress on the body, disrupting the GnRH pulses from the hypothalamus. Common scenarios: significant weight loss or low body weight, like in anorexia, intense exercise, especially in athletes without enough calorie intake, chronic emotional or physical stress. Key insight: leads to low GnRH, low LH-FSH, low estrogen, and thus amenorrhea. Long-term risks include low bone density and infertility. Treatment is addressing the underlying cause: better nutrition, less extreme exercise, stress management, maybe estrogen replacement.
And the Fragile X link with POI.
Yes, women who carry the Fragile X premutation, 55-200 CGG repeats in the FMR1 gene, have a much higher risk of developing POI, often years earlier than typical menopause. Key insight: they might have anxiety, depression, or a family history of Fragile X syndrome. The mechanism is thought to be toxic effects of the abnormal FMR1 mRNA on the ovarian follicles, causing them to deplete faster. So FMR1 testing is often recommended for women with unexplained POI under 40.
Okay. Endometriosis, common cause of pelvic pain. Symptoms and exam findings.
Endometriosis is endometrial tissue growing outside the uterus, causes chronic pelvic pain, often 6 months. Classic symptoms: painful periods, dysmenorrhea that might get worse over time, non-cyclic pelvic pain, painful sex, dyspareunia, sometimes painful bowel movements, dyschezia, infertility. On exam, you might find tenderness, especially behind the uterus, posterior cul-de-sac, nodules felt on rectovaginal exam, or a fixed non-mobile uterus. But a normal exam doesn't rule it out.
Diagnosis and management.
Definitive diagnosis requires seeing the implants, usually via laparoscopy, and getting biopsies. Ultrasound might show an endometrioma, an ovarian cyst with that classic ground glass look, but often misses smaller implants. Management depends on symptoms and goals. Medical options aim to suppress hormones: OCPs, progestins, GnRH agonists, antagonists. Surgical options involve removing or destroying the implants laparoscopically. can range from simple ablation to hysterectomy in severe cases if fertility isn't desired.
Got it. Polycystic ovary syndrome, PCOS, diagnostic criteria.
PCOS is a common endocrine issue. Need at least 2 of these 3 Rotterdam criteria. 1, irregular periods, oligo or anovulation. 2, signs of high androgens, clinical like hirsutism acne or biochemical like high testosterone. 3, polycystic ovary seen on ultrasound, many small follicles or large volume. Key insight: just seeing polycystic ovaries isn't enough. Need the other criteria too.
Pathophysiology and comorbidities.
Complex. Key factors often include insulin resistance, leading to high insulin, which drives ovarian androgen production, and an HPO axis imbalance, often high LH relative to FSH. This leads to the androgen excess and problems with ovulation. Big comorbidities to watch for: metabolic syndrome, type 2 diabetes, sleep apnea, fatty liver disease, NAFLD, and higher risk of endometrial hyperplasia cancer due to chronic lack of ovulation. Also, higher rates of anxiety, depression.
Treatment approaches.
Tailored to the patient's goals. First line for overweight women is often lifestyle changes. Weight loss improves insulin sensitivity and hormones. OCPs regulate cycles and help with acne hirsutism. For fertility, ovulation induction meds like clomiphene or letrozole are used. Metformin can help with insulin resistance. Spironolactone for hirsutism.
Pelvic inflammatory disease, PID, hallmarks.
PID is infection of the upper female reproductive tract, uterus, tubes, ovaries. Key clinical signs: lower abdominal pain, pelvic tenderness on exam, and especially cervical motion tenderness, CMT. Extreme pain when moving the cervix during the bimanual exam. Also, often uterine or adnexal tenderness. May have abnormal discharge. Fever often starts around the time of menses.
Diagnosis and treatment.
Mostly clinical diagnosis based on those exam findings. Labs like high WBC, CRP, or positive GC chlamydia tests support it. Ultrasound can show complications like tubo-ovarian abscess, TOA. Looks like a complex multiloculated mass near the ovary tube. Treatment is prompt antibiotics to prevent long-term issues like infertility or ectopic pregnancy. Can be outpatient or inpatient. Outpatient often involves IM ceftriaxone plus oral doxycycline, maybe add metronidazole. Inpatient for severe cases, TOA, pregnancy, etc., uses IV regimens like cefoxitin, doxy, or Clinigen. Need good anaerobic coverage like metronidazole or Clolusia if there's a TOA.
Okay. Oral contraceptives, benefits beyond contraception. Side effects, risks.
Benefits: regulate cycles, reduce bleeding anemia, help period pain, lower risk of ovarian and endometrial cancer, help manage PCOS symptoms like acne hirsutism. Side effects, risks: common ones are nausea, breast tenderness, headache, bloating, breakthrough bleeding initially, more serious but rarer risks. Blood clots, VTE, slightly higher risk of stroke MI, especially if smoker 35, maybe small increase in cervical cancer risk with long-term use, rare liver issues, could affect blood pressure, lipids.
Absolute contraindications to combined OCPs.
Definitely. History of VTE, DVTP, stroke, heart attack, current or past breast cancer, active liver disease or liver tumors, uncontrolled severe hypertension, migraines with aura, smoking 015 cigarettes day of over 35, diabetes with vascular complications, known thrombophilia, pregnancy, major surgery with prolonged immobilization. Those are the big ones.
Okay, migraines, acute versus preventive therapy.
Acute treatment, abortive. Triptans are often first line. NSAIDs can work too. Antiemetics for nausea. Ergots are less common now. Preventive therapy, if frequent severe. Beta blockers, some antidepressants like amitriptyline, some anticonvulsants, topiramate, valproate. CGRP inhibitors are newer options.
Abnormal bleeding while on OCPs. Always concerning.
Breakthrough bleeding is common in the first few months. Usually light, often resolves. Key insight: persistent or heavy bleeding needs evaluation. Could be the pill formulation isn't right, missed pills, drug interactions, or an underlying issue like fibroids, polyps, infection. Needs a closer look if it doesn't settle.
Emergency contraception options and timing.
Most effective: copper IUD up to 5 days after, 99% effective. Contraindicated if active infection, distorted uterus, Wilson's, oral options. Ulipristal acetate, Ella, up to 5 days, 98–99% effective. Levonorgestrel, Plan B, best within 3 days, up to 5 days with decreasing efficacy, maybe 59–94%. High-dose combined OCPs, use B, less effective, more side effects. Key for pills: sooner is better.
Vaginal cancer. Presentation and risks.
Rare. Might present with abnormal bleeding, postmenopausal, postcoital, smelly discharge, or a visible lesion ulcer, often upper posterior vagina. Advanced. Pain, urinary bowel symptoms. Risks: older age 60, high-risk HPV, history of cervical vulvar cancer dysplasia, DES exposure in utero for clear cell type, smoking. Diagnosis by biopsy:
Desquamative inflammatory vaginitis.
chronic inflammation, Key feature, copious watery discharge, inflamed red vagina. Wet mount shows lots of white blood cells. pH is high. Treatment often involves topical steroids.
Tamoxifen effects on the uterus.
It's a SERM. Blocks estrogen in the breast, but acts like estrogen on the uterus. Key insight. Can cause endometrial thickening, polyps, and increases risk of endometrial cancer, especially postmenopausally. Any bleeding on tamoxifen needs an endometrial biopsy. Also increases VTE risk, can cause hot flashes, but good for bone density. Raloxifene is another SERM, less uterine risk.
Secondary amenorrhea evaluation after ruling out pregnancy.
Initial labs. Prolactin. Rule out hyperprolactinemia, TSH. Rule out thyroid disease. Then consider FSH-LH. Assess ovarian function versus hypothalamic issue, and maybe androgens depending on clinical picture. History of uterine surgery. DNC raises concern for Asherman's syndrome. Adhesions.
PID revisited subtle symptoms. Fitzhugh-Curtis.
Subtle PID symptoms might just be changed discharge, irregular spotting, pain with sex, risk factors, young age, 25, multiple partners, new partner, history of STIs, inconsistent condom use. Fitzhugh-Curtis, perihepatitis, is inflammation around the liver capsule from ascending infection, often GC clam. Causes sharp right upper quadrant pain, often worse with breathing. Can mimic gallbladder pain.
Intrauterine adhesions. Asherman's. Risks and presentation.
Scar tissue inside uterus. Risk factors. Uterine procedures, especially DNC after pregnancy or with infection. Myomectomy 2. Presentation. Can cause light periods, no periods, infertility, recurrent miscarriage, cyclic pain if outflow blocked. Diagnosed usually by hysteroscopy.
Urethral prolapse visual. Acute cervicitis cause findings. Labial adhesions cause.
Urethral prolapse. Donut-shaped reddish tissue at urethral opening. Acute cervicitis. Mostly GC chlam. See, purulent discharge from cervix. Cervix looks red, bleeds easily, friable. Diagnosed with natalitz, labial adhesions, usually due to low estrogen, pre-pubertal girls, or chronic inflammation irritation. Labium and minor stick together.
Okay, quick compare-contrast. BV, Trich, yeast, discharge pH findings.
BV, thin, white-gray, fishy discharge, pH 4.5. Clue cells, positive whiff test, no inflammation usually. Trich, yellow-green, frothy, smelly discharge.
Yeah.
pH 4.5. Modal strichomonads on wet mount. Inflammation common, strawberry cervix. Yeast, thick, white, cottage cheese discharge, normal pH 3.8, 4.5. Kudo hyphae yeast on KOH prep. Inflammation itching common.
Vulvovaginal candidiasis. Risk factors. Recurrent infections.
Risks, diabetes, immunosuppression, pregnancy, OCPs, antibiotics. Symptoms, itching, white discharge, redness, burning. Diagnosis, normal pH, yeast on KOH. Recurrent warrants checking for underlying issues like diabetes, HbA1c. Treat with antifungals, fluconazole.
Bacterial vaginosis key features. Amsel criteria.
Features, thin, gray, fishy discharge, no inflammation. Labs, pH of 4.5, clue cells, positive whiff test. Treat with metronidazole or clindamycin. Complications, higher risk of preterm birth, acquiring other STIs. Amsel criteria, you need 3 of 4. 1, characteristic discharge. 2, pH 4.5. 3, clue cells. 4, positive whiff test.
Obesity and an ovulation mechanism.
Obesity, insulin resistance, Hindle and ovaries make more androgens, also lower SHBG, more free androgen. Peripheral conversion of androgen to estrone disrupts GnRH pulses, favors LH over FSH, no LH surge, no ovulation. Leads to irregular cycles, AUB. Treat with weight loss, OCPs.
Hidradenitis suppurativa, 5-alpha reductase deficiency versus AIS. Klinefelter.
HS. Chronic inflammation in skin folds, groin, axilla, painful nodules, abscesses, sinuses, scarring. Risk factors, obesity, smoking. 5-alpha reductase deficiency, 46XY, can't make DHT. Female external genitalia at birth, virilize at puberty, normal male internal. AIS, 46XY. Androgen receptor defect. Female phenotype, breast development but no uterus, upper vagina. Minimal pubic axillary hair. Testes present, need removal later. Klinefelter, 47,000XY. Tall and fertile small testy, gynecomastia, learning issues.
Recap endometrial biopsy indications again, and PAP needing EMB.
EMB indications. Age of 45 with AUB PMB, age 45 with AUB plus risk factors, unopposed estrogen, failed meds, Lynch, PMB, endometrial cells on PAP postmenopausally. AGC on PAP 35 or with risks. PAP needing EMB. Any endometrial cells postmenopausally, AGC 35 or with risks.
Barthel and duct cyst. Location, cause, treatment, differentiation.
Location. 4 and 8 o'clock. Posterior vaginal opening. Function. Lubrication. Cause. Blocked duct. Mucus. Inflammation. Features. Soft, mobile, usually painless mass. Treatment. Observe if asymptomatic. Incision and drainage word, catheter marsupialization if symptomatic infected. Differentiate from Gartner, lateral upper vagina, Wolffian remnant, and Skene, with the side urethra anterior.
Okay, urinary incontinence types in more detail. Stress, urgency, mixed, overflow.
Stress, SUI, leak with cough, sneeze, laugh. Cause, weed pelvic floor, urethral hypermobility. Urgency, UUI, sudden urge, can't hold it. Cause: detrusor overactivity, mixed MUI, both SUI and UUI symptoms. Overflow: leakage due to bladder not emptying well. Cause: outlet obstruction or weak bladder muscle.
Management of mixed interstitial cystitis.
Mixed: start with behavioral, bladder training, giggles, avoiding diary lifestyle. Then consider meds, antimuscarinics for urgency, or surgery, sling for stress. Interstitial cystitis, bladder pain syndrome. Chronic bladder pain, worse with filling, relieved by emptying. Frequency, urgency, no infection. Diagnosis of exclusion. Treatment is symptom-focused, behavioral, diet, meds like amitriptyline, PT, pain management, not curative.
Candida recap risks, treatment.
Risks: high estrogen, diabetes, antibiotics, immunosuppression. Symptoms: itch, white discharge, redness. Diagnosis: normal pH, yeast on KOH. Treatment: antifungals, topical or oral fluconazole.
Benign breast stuff.
Correct.
Introductal papilloma hallmark. Other benign types.
Introductal papilloma. Unilateral bloody nipple discharge, usually no mass, other benign. Fibrocystic changes, cyclic pain lumps.
Yeah.
Fibrodoma, smooth, mobile, solid mass, young women. Fat necrosis, firm, irregular, history of trauma surgery. Simple cysts, fluid-filled. DCIS is precancer, microcalcifications.
Mammary Paget disease. Physiologic galactorrhea.
Paget disease. Eczema-like rash on nipple areola, scaling, itching, maybe bloody discharge. Almost always underlying breast cancer, DCIS or invasive. Needs biopsy mammo. Physiologic galactorrhea. Bilateral, milky clear discharge, not bloody. Causes: meds, dopamine blockers. Pituitary issues, hypothyroidism. Check prolactin, TSH, maybe MRI of prolactin high.
Inflammatory breast cancer versus lactational mastitis.
Apostasy. Rapid onset swelling, redness, warmth, put orange skin. Often no distinct mass. Doesn't improve with antibiotics. Needs biopsy. Mastitis. Usually focal redness, tenderness, lump in breastfeeding woman. Often fever flu-like symptoms caused by Staph aureus. Treat with antibiotics, keep breastfeeding pumping. Improves with treatment.
Simple breast cyst evaluation management. Mastalgia approach.
Simple cyst, smooth, mobile, maybe tender. US first of 30. Looks anechoic with posterior enhancement. If symptomatic, can aspirate. Clear fluid, mass resolves, observe. If bloody recurs residual by biopsy. Nostalgia. Cyclic, diffuse bilateral. Para-reassurance, support bra, NSAIDs. Non-cyclic, focal unilateral, imaging, MEMI to rule out pathology.
Postmenopausal bleeding approach. Toxic shock syndrome.
PMB, always needs evaluation. Pap test plus endometrial assessment, EMB or TVUS. If TVUS read 4 millimeter EMB. Treatment for hyperplasia cancer, usually hysterectomy plus BSO. TSS, high fever, hypotension, diffuse rash, palm soles, multi-organ issues. Cause: staph strep toxins, tampons, wounds. Treatment: fluids, supportive care, antibiotics. Vanco plus Clinda for staph.
Disseminated gonococcal infection triad.
Pustular dermatitis, skin lesions, tendinosynovitis, tendon sheath pain swelling, migratory polyarthralgia, joint pain moving around.
Acute pelvic pain differentials. Algorithm. Adnexal mass investigation. Pudendal neuralgia.
Differentials: Mittelschmerz, ectopic, torsion, ruptured cyst, PID, appendicitis, stones. Algorithm: first, pregnancy test, positive pelvic US. Negative, consider CT, appy stones, or further GYN workup. Adnexal mass. Pregnancy test, pelvic US first. CT MRI is suspicious. CA-125 may be helpful postmenopausally. Pudendal neuralgia. Pain in vulvopernium rectum distribution, often worse sitting.
Mullerianogenesis key features. Vulvar SCC recap.
Mullerianogenesis, MRKH. Absent uterus, uvusecra, vagina. Normal ovaries, normal female secondary sex characteristics, 46.
Yeah.
Need real US, associated anomalies common. Management: vaginal dilation creation, vulvar SCC, persistent itch, lump pulse or plaque, bleeding, pain.
Ovarian reserve decline. Cervical insufficiency.
Ovarian reserve. Number quality of eggs drop sharply after 35. Infertility definition is 6 months trying if 35. Cervical insufficiency. Painless cervical shortening, dilation, and secondarily third trimester. Risks: prior cervical procedures of obstetric trauma, multiple gestation. Diagnosis: history, US showing short cervix and 25 millimeter. Management: cerclage.
Adenomyosis details. Erosive lichen planus. Sicca syndrome.
Adenomyosis. Endometrial tissue and myometrium. Presents 40, multiparous with heavy, painful periods, maybe chronic pain. Uterus often enlarged, boggy, tender. Definitive DX histology post-hysterectomy. Erosive LP. Painful red erosions on vulva vagina, often with white Wickham striae. Can cause scarring stenosis. Oral lesions common. Treat with potent topical steroids. Sicca syndrome. Dry eyes, dry mouth, dry vagina. Due to exocrine gland dysfunction, Sjogren's or secondary to other autoimmune. DX symptoms: Schirmer test, antibodies, ROLA, maybe salivary biopsy.
Contraception quick hits. Copper versus levonorgestrel IUD. Medroxyprogesterone IUD contraindications.
Copper IUD. Inflammation, toxic to spermova. Can increase bleeding. Levonorgestrel IUD. Thickens mucus, thins lining, less bleeding, gonorrhea. Good for heavy bleeding. hydroxyprogesterone, depot, injection Q3 months, weight gain common, IUD contraindications, pregnancy, current PID cervicitis, uterine to cervical cancer, unexplained bleeding, distorted cavity, GTD, also active liver, disease breast cancer for LNG IUD, Wilson's for copper.
Primary infertility workup start, breast cancer risks, BRCA suspicion management.
Primary infertility, 35. Failure after 1 year trying. Initial workup includes ovulation assessment, semen analysis, and hysterosalpingogram HSG to check tubes uterus, breast care risks. Age, genetics, BRCA, family HX, early menarche, late menopause, nulliparity, obesity post-meno, alcohol HRT, BRCA suspicion, early onset breast K50, ovarian K any age, triple neg 60, bilateral breast K, male breast K, Ashkenazi Jewish ancestry, management, increased surveillance, MRI mammo, risk-reducing meds, tamoxifen, prophylactic surgery, mastectomy, BSO.
Endometrial cancer risks evaluation group.
Risks: unopposed estrogen, obesity, PCOS, nulliparity, early menarche, late menopause, tamoxifen, Lynch syndrome, presentation, AUB, PMB, evaluation, endometrial biopsy, gold standard, TVUS, helpful post-mano treatment, hyperplasia Y, atypia, PNA, progestas, hyperplasia W, atypia or cancer, day hysterectomy plus BSO. Tobacco slightly decreases risk.
Candida intertrigo, genitopelvic pain disorder, ovarian torsion risk presentation.
Candida intertrigo. Beefy red plaques and folds, satellite lesions. Risks: obesity, moisture, diabetes, immunosuppression. Treat: topical antifungals. Genitopelvic pain, pain difficulty with penetration. Risks: trauma history, anxiety. Treat: PT, desensitization, therapy. Ovarian torsion, risk with large mass, teratoma, sudden severe unilateral pain, NV, US enlarged ovary, absent Doppler flow maybe. Treat: surgery, detorsion plus phonicystectomy, oophorectomy.
Mature cystic teratoma, ovarian hyperstimulation syndrome, HSV primary infection.
Teratoma, dermoid, benign germ cell tumor, contains hair, teeth, fat, risk of torsion, US complex cystic calcifications. Treat: surgery, OHSS, complication of fertility meds, VHSV, sites, pleural effusion, hemoconcentration, thromboembolism risk. Manage: supportive fluids, grain fluid, VTE prophylaxis, HSV primary, multiple painful ulcers, fever, malaise, tender nose, dysuria, viral culture, PCR diagnosis.
There's urethral diverticulum, gestational age assessment, anogenital warts in kids.
Urethral diverticulum, outpouching of urethra, symptoms. Postvoid dribble, dysuria, UTIs, tender anterior vaginal mass, DX, MRI TV US, gestational age. Most accurate is first trimester CRL on US. Use LMP if consistent, otherwise US states. Warts in kids, HPV. Assess for sexual abuse, SP4. Manage, observe, or treat, topical surgical.
Physiologic leukorrhea, ovarian hyperthicosis, imperforate hymen, ruptured ovarian cyst.
Leukorrhea. Normal white clear, odorless discharge, varies with cycle. Hyperthicosis, postmenopausal virilization, insulin resistance. US solid enlarged ovaries, imperforate hymen, primary amenorrhea, cyclic pain, bulging blue membrane, and introitus. Treat: Step2CK. Ruptured cyst. Sudden pain, often after activity sex. US simple cyst plus free fluid. Manage, observation if stable.
IPV screening, rational management, osteoporosis risks, IIH features diagnosis.
IPV screen. High prevalence, serious consequences, injury, mental health, homicide, often not disclosed. Management: ensure safety, document, safety plan, resources, referrals. Osteoporosis risks: age, female, low weight, race, white Asian, early menopause, estrogen deficiency, smoking, alcohol, inactivity, certain meds diseases, IIH. Obese women, childbearing age. Headache, vision changes, pulsatile tinnitus, papilledema. DX, normal imaging, high LP opening pressure. Treat: weight loss, acetazolamide.
Wow. Okay, we have definitely covered a huge amount of crucial gynecology today.
Absolutely. We really try to hit the high points for the exams using those clinical scenarios to hopefully make it stick.
Yeah, that vignette approach is key. And given just how much material there is, definitely, go back and review sections that maybe felt a bit fast.
Exactly. And remember, knowing this stuff isn't just about passing tests. It's about understanding these conditions to provide really good, compassionate care. Think about how all these things, hormones, anatomy, lifestyle, all weave together to affect women's health. It's a continuous learning process.